So, welcome to the section on access and affordability in pharma. Now, when you're working with your clients to create a campaign, you want to really understand how you can create messages and communication campaigns that will cause people to take an action. Whether that's a physician writing a prescription or a patient going to the doctor and asking for a prescription or filling a prescription, you need to motivate people to take action. To do that effectively and to be a true strategic partner with your client, you need to know more about the system in which these actions are taking place. So, in this section, in this lesson, I'm going to give you an overview of the US and the global healthcare system so that you can better understand how this environment works, both in the US and ex US. At the end of this section, you're going to be able to understand how the history of our healthcare system has shaped current access. You'll be able to explain the concept of pooling, which is incredibly important to understand health in our country and others. Describe the role of the pharmacy benefit manager, be able to tell global healthcare systems apart and how they impact pharma marketing, and understand how tender agreements affect pharma access ex US. So let's get started. So, as we take a look at the early days of organized healthcare, US hospitals really weren't places for people to kind of go whenever they get sick. It was really more for people that couldn't afford, that were maybe homeless or couldn't afford a nice home or couldn't afford for a physician to come to them. And so most people, when they got their care, they got them in their home, and the physician would come to them, and it was a fee for service model, which the physicians provided a service and you gave them a fee. So you'd be sick, you'd call the physician, they come to your house and you pay them, and they do their care and they'd leave. Um, Drugstores at the time were much more art than science. There was a lot of herbal medications, but there just weren't the kind of drug discoveries we have today. So a lot of times there weren't consistency in those formulations. It was really kind of hit or miss. So in 1912, Teddy Roosevelt tried to push national healthcare system. He was really inspired by the United Kingdom's healthcare system, which started in 1911, and he tried to do it here in the United States, but he was defeated. This timeline shows you kind of this overall history, a very high level of health insurance in the US. And it's kind of important to understand our history because there's a couple of things that really impact it. One is you can see that as early as 1880s, there was this accident insurance that was offered. So it was like paid hospital care. And it also repaid for any repairs needed to property. So it was kind of all together. It was kind of your accident insurance. It covered your health care as well as, anything that got hurt on your property. Then something really interesting kind of started to happen. You had two things that kind of come together. One is 1920s, this hospital in Dallas, Texas called Baylor Hospital did something revolutionary. Now they had empty beds and they were trying to figure out how they could fill their beds and how they could make money and stay in business. And they came up with this idea of a prepaid service plans. And so at the time, there were a couple of really nice cosmetics that were on the market, lipsticks. And they really wanted to think about, having people buy lipstick, which wasn't something that, people really bought a lot. And so they offered some kind of, hey, you buy this lipstick. It was almost like a subscription service, and you pay a little bit each month and you get your lipstick. So they wanted people to pay for healthcare the same way they paid for their lipstick, a little bit each month, which was the beginning of monthly premiums. Then in 1930, Baylor Hospital and these physician offices that were also doing the same thing, prepaid services, they changed their name to the Blue Cross and Blue Shield, and they sold their prepaid plans to the Texas Teachers Union. Now, when you save a plan and you sell a plan to the Texas Teachers Union, you are likely selling it to women. And so one of the things that they did in this plan is that they offered prepaid hospital services for maternity care, because a lot of these young women were at childbearing age and they were going to be having babies. And so what the plan was doing was really pricing itself based on this very expensive, likely needed service, which was maternity care. They were able to spread the risk across all of the women, and everybody was paying in a little bit based on what they would need typically during a maternity, stay in a hospital. So it was a very easy way for them to price it out and to sell it. And so they sold it to the Texas Teachers Union, and it was so successful that the Texas Teachers Union, of course, because they're a union, they paid a portion of the premium, and then the teachers paid a portion of their premium. So it was a really great benefit. It got people to join the teachers union really fast. But what this was the first time that employees and a plan was funded partially by employers really caught on, and so soon many companies started offering these prepaid plans. Then something happened that really accelerated the adoption of these plans, and it was World War II. World War II The country was entering a very expensive overseas war on two fronts, both in Europe and Japan, and so they put a wage freeze on. It made it very difficult for employers to attract workers. So what these employers started doing was offering healthcare plans in larger and larger numbers as ways of attracting workers. Now, there were lots of experiments to see how better to manage health and healthcare. In fact, Kaiser Permanente was formed during World War II. They started paying doctors in this brand new way by capitation. So instead of paying, for each of the services or paying doctors based on the services that they delivered, they paid each physician a set monthly fee based on the number of patients that they were in charge of. And so it was the first time that capitation was put in place. It was the first HMO. And it was also the first time that doctors were kind of incentivized to keep patients healthy. So they, kind of started that system. In 1940, there was a very kind of important act that was passed called the Taft-Hartley Act, named after the two politicians who passed it. What this Taft-Hartley did is it made it lawful for unions to collectively bargain for health insurance coverage as part of their pay. And that Taft-Hartley Act formalized something that had been in development where it was the consideration in the United States that your health coverage is part of your pay. So it really connected as an employee benefit. And that's something that still exists today, where the healthcare coverage is still seen as being part of your compensation package, so part of your pay. Now, in the 1960s, Medicare was signed into law to provide care for people over the age 65. In the 80s, COBRA was enacted to allow people who leave a job to take their health care with them for a period of time. The Health Information Privacy and Portability Act was put in place in 1990s. It brought a lot of additional safeguards to patient data, but it was also designed to somehow make the data electronic so it could eventually be portable. And then the Children's Health Insurance Program helped provide health care to low-income children and still exists today. Sometimes that's shortened in client conversations to CHIPS. Medicare Part D, which is the prescription drug coverage for Medicare, went into place in 1990. The Affordable Care Act was signed into law, requiring many changes to the system, including making health care coverage compulsory. And all these laws and events have helped shape this really complex system that we have in the U.S. today. Now, to really understand health insurance and its influence and why certain, the U.S. works in some ways and other countries work in other, you have to understand this idea of pooling. So let's just take a second to understand pooling. So pooling is this concept of spreading risk. So the idea is you have all these different people in the pool, and they have different levels of health risk. Some are really sick, some are really healthy, and the plan will assess the cost or the probable cost of their care in an average year. And then the cost is divided equally among all of them. So when you do that, you have your healthy people that are probably paying more for their healthcare coverage than they will likely need, and you have your sick people paying less than they will likely need in healthcare coverage, and everything kind of evens out. Now, the health insurance industry uses pooling to spread risk across varied populations. So the idea is that those who are healthy help offset the cost for those who are ill. Now, as you can tell, pooling only works if you have a good variety of people in the pool. If you have a pool of really sick people, that's not really going to help those sick people because the cost of their care is going to be too high for them to afford. Having a pool of people that are all really healthy also doesn't really incentivize them because it's very low cost coverage, but they also don't need it. So pooling only works if you have enough people to spread the risk evenly. And the problem that we have in the United States is that a lot of young people who are healthy, they don't want to buy insurance and pay a high price. The reason they'd have to pay a high price than they would need is because there are sicker people. And right now in our country, we have baby boomers, which is one of the largest generations we've had, and they're aging, and you have Generation X coming along behind them that's much smaller. They can't afford to pay for all of their care because we have fewer numbers of people in our generation than the baby boomers do in theirs. Then you have Generation Y, who is a little bit bigger, and so the generational thing will start to level out in the next few years, but it's been really challenging for a while as we've had these increased cost of baby boomers as they're aging, and we also have a lot of additional developments and discoveries that are enabling people to live longer, more active lives, but also take years and years of pretty expensive medications. So it tends to be sometimes a challenging situation to be in. But that's the idea of pooling. Another thing that's important to understand as we start to talk about the pharmacy benefits are a couple different concepts. These are probably real familiar to you, so I'll go through these pretty quickly. Formulary, that's just your list of drugs that are available on the drug plan. You have to be on the formulary in order for patients to be able to access your drugs at a low cost. That's why your clients are going to be really interested to make sure that they're on the different formularies for different particular health plans. Tiers of benefits are important. So pharmacy, products typically have tiers. They'll be on tier 1 if they're generic, tier 2 if they are branded, but maybe, very much proven. You've got tier 3, which is your branded medication, and tier 4, which was not usually, sometimes added. Tier 4 and tier 5s are used more for drugs that they want to really restrict the use of. So maybe, Botox for migraine might be on tier 3, but Botox for your aesthetics might be on tier 5 if it's even on the formulary at all. And then you've got pharmacy benefit and medical benefits, which are two different things. And the important thing to know there is that your pharmacy benefit is adjudicated right there at the pharmacy. So you have that kind of really rapid, understanding of what you pay. So it's immediate. Medical benefit works a little differently and takes a little bit longer. And what's important about that is that sometimes you'll have drugs like that, specialty drugs that are infused drugs that are injected, drugs that are oncology drugs, anything that kind of is a little bit different than what you would find in a traditional pharmacy. That's called a specialty drug. And specialty drugs are usually dispensed by a specialty pharmacy, and that specialty pharmacy, really are experts in storing, keeping those drugs secure. A lot of them, especially like pain medications, they're controlled substances. They have to have additional safes and things like that. So they have all of this real kind of, safeguards in place, and they have this process around it. So they tend to be a little bit, more experts at understanding how to dose and deliver specialty drugs. And they sometimes are located in a strip mall, or they're located in a hospital. So they can be kind of special areas too. And those specialty drugs run through the medical benefit. So if you're talking about launching a new drug, maybe it's a biologic, maybe it's an oncology oral drug, it's important to ask for your clients, is this drug going to run through the medical benefit? Is it a specialty product? And understand what that means, because if it's a medical benefit, the patient pays almost nothing for it. So this whole idea of cost or copay or tier, really not important. The only important thing is getting on the formulary. So let's talk about something called the pharmacy benefit manager, as well as how the system works overall. And you have these kind of different players in the market. You have all the way over on the left, you have the manufacturer. That's the client. That's the person who's making the drug. So that's usually where our client's sitting. Right below that, you have the pharmacy. That's the retail pharmacy. There's one on every corner, and that's where people go to get their drugs. Way over on the right, you have the insurance company, which is the one that's typically paying for those drugs. And then you have the consumers right below them that need drugs and take the drugs. And in the middle, you have this person called the pharmacy benefit manager. And this is a really unique group that usually works directly with the insurance company. And they help kind of moderate the flow of money back and forth between the pharmacy and the insurance company and the consumers and the manufacturer. So the easiest way to understand what a pharmacy benefit manager does is to track the money. So let's start. First, the consumers are going to pay a premium to the insurance company. Then they're going to go to the pharmacy, and they've got their prescription. They're going to get their drug. They're going to pay a copay to the pharmacy, or coinsurance, which is a percentage of the cost. Or maybe they have to pay additional, and they'll pay that out of pocket, or OOP. The pharmacy then pays for the drugs to the manufacturer or a wholesaler. Then they will get some money from the pharmacy benefit manager, who will pay them something called a network fee or a fill fee. Network fees are what the pharmacy benefit manager will pay the pharmacy for signing up for the pharmacy benefit manager's network. The pharmacy benefit manager contracts with all the pharmacies, puts them into a network, and sells them to insurance companies. Now, each of the insurance company will have different employers and different plans, and they'll negotiate differently based on those pools of patients that we talked about before and their healthcare needs, and they'll negotiate different network fees and different fill fees for each of these networks with the pharmacy benefit manager. Because the network fees and the fill fees are different by the type of contract that was negotiated, that's part of the reason that you can go to one pharmacy and your prescription will be one cost, and go to another pharmacy and your prescription will be a different cost. So the insurance company is paying to the PBM management fees, network fees, fill fees for these different access to these pharmacies. And then the pharmacy benefit manager will pay the manufacturer for the drugs that they contract with. Now, they're going to have some lower prices, and because they have so many people that they are managing the lives of and they have so many pharmacies, they can negotiate really low bulk prices from the manufacturer. But the manufacturer doesn't want to give those low prices unless they're absolutely sure that the pharmacy benefit manager is going to use that much drugs. They don't want to offer a low price and then have the pharmacy benefit manager say, oh, well, I only ended up using half of those drugs. So they do something called rebates. And the rebates that they would pay to the pharmacy benefit manager is an amount of money that would basically equal giving them a really low price, but they only pay them at the end of the year after the pharmacy benefit manager has fulfilled their quota. Then the pharmacy benefit manager will pay part of those rebates to the insurance company. The insurance company, knowing they're going to get these great rebates, will put those brands on formulary. That's it. Another thing that's important before we start to dive into these international health systems is just really quick about Medicare and Medicaid in the U.S. There's a whole lesson on Medicare and Medicaid, so I'm not going to go into too much detail. It's just important to know that Medicare is the healthcare coverage that's given to those who are ages 65 years and older in the U.S. If you're disabled or if you have end-stage renal disease, you can also get that coverage. There's different parts of it, parts A, B, C, D, there's F, G, H, and others too, but we'll talk about those. It's a federal program administered and paid for by the U.S. government. And it is, there's something called Medicare Advantage that's been growing very rapidly, and that's a private insurance offering that's contracted with the government. On the other side is Medicaid. That's for limited income individuals, those who have limited income and resources. Now, it's both federal and state. So the federal, the U.S. government gives the states a set amount of money for their populations based out of the, the population and their health. And then the state runs the program. So the state decides what the coverage is, what the cost would be for certain programs. Sometimes the state adds a lot of money to it, and it's a very rich program. Sometimes they don't, and it's not a very rich program, but it varies by state. There's something called dual eligibles. That's somebody who is very sick and possibly also poor, and that is somebody who's going to have Medicare and Medicaid covering them to help with the costs. And that's something that you'll deal with if you have any drugs that are being launched in end-stage renal disease or somebody with Lou Gehrig's disease, then they're going to have, dual eligible for those populations. So now let's dive into international health systems and talk about what you need to know when you're launching a brand globally. So there's 4 different types of healthcare systems that you can see here, and we're going to talk about each one. The first is the beverage model. Now, the beverage model is the model that's used in Great Britain, New Zealand, Spain, Cuba, and several other countries, but this just to kind of give you an idea. But I think the easiest one is to think about Great Britain. That seems to be the one that most people are familiar with. Now, in the beverage model, the healthcare system is all provided by the government. It is a government-run system. The government is the one that is creating the program. The government is the one that is, hiring the doctors and the nurses and the hospitals. Think of it like the police force. It's kind of an easy way to think about it, is that the government owns the hospitals and clinics. They're deciding where the hospitals get built. These systems really have low cost per capita because it's the government. And they have a pool of everybody, so their risk is spread across all of the population. And it's something that they, really are able to kind of keep the costs down and control all of the different aspects of the coverage. So what this feels like when you're going through the system is that you're a patient and you break your arm. You can go to a physician of your choice. Now, it's moderate choice. You can't just choose any physician. And it's a little bit like public schools. You can't just choose any public school in most of our U.S. cities. You have to choose a school that's within the area that you are living. Similar with the UK and the physicians, you choose a neighborhood physician and you register with that physician's office, and then that's your physician. Now, you can always go outside of that physician and go to somebody else. Just like in the US, you can go to a different school, but if you went to a different school, you might have to pay. It might be a private school and you'd have to pay for it out of your own pocket. Same way with going to a different doctor in the UK. But in the UK, if you go to that doctor that's in your neighborhood, you don't pay anything. You don't pay really anything for the pharmacy. You're going to, really, I think pharmacy costs are really minimal, about £9 per prescription in the UK. Exemptions exist for chronic conditions. So it's very easy to kind of get the medications. Now, it's important to know in the UK that pharmacists are independent prescribers. So pharmacists in the UK can prescribe any medication for patients within their area of competence. So they have to take a little bit additional education, but then they take education around dermatology, they can write a dermatology prescription. And so what they usually do is they usually write prescriptions if it's a repeat prescription, or maybe modifying the prescription. If you come back to the pharmacist and you're like, this isn't this, I'm getting nauseous from taking this, they might adjust the dose a little bit. So they can do some things like that. They typically don't see patients diagnose a condition and then write a prescription, but they do have the ability to adjust prescriptions. They don't have to always call the doctor back to get approval the way we do in the US. The next type of system is the Bismarck system. And the Bismarck model is used by France and Germany, the Netherlands, Japan. And this insurance system is kind of a little bit of a hybrid between the federal government and private. So this insurance system involves the government setting up what are called sickness funds, and then everybody pays into them. So employees pay into them, employers pay into them, and the government pays into them. So all three people are kind of paying into them. The government really controls most of it, has a lot of specific, really tight regulations. But then the doctors and the hospitals tend to be private. They're not necessarily going out and owning all of those. And it's usually paid for, by a payroll deduction, so that if you're not working, you don't pay for it and you still benefit from it. But again, everybody's included, nobody's denied coverage, so you've got the risk that's spread through the entire population, and you can go to just about any physician you want. In the Bismarck model, if you broke your arm, you'd get to go to whatever physician you wanted. Some of the specialists might cost a little bit more, may not be, reimbursed as highly if you go to a specialist on your own, but pretty much you can go to anybody you want. And you pay about 15%, so the sickness fund covers about 85% of care. Generic prescriptions are covered, but you have to pay, it's a tier structure, and you have to pay a co-insurance. You pay 15% for generic drugs, usually about 30% for lifestyle, and then maybe 65% for branded drugs. And then the important thing to understand here is that they can't necessarily, like in France, pharmacists can't write prescriptions like they can in the UK, but they are super personalized services, and they really know their patients, and they're providing a lot of handwritten instructions, and they help with adherence. So the pharmacist tends to be a pretty important person in this type of plan. The next one we'll talk about is the national health insurance model. That's used by Canada, Taiwan, South Korea, and China. Canada is probably the one that we're most familiar with. And this is where the payment comes from a nationally run insurance program. Every citizen pays taxes, but there's no profit. There's only one plan type, and the plan is something that is owned, not the whole entire system. So in the United Kingdom, the whole entire system is owned by the government, like it's a police force. In Canada and Taiwan, and the national health insurance model, it's just a national health plan that everybody gets an access to through their taxes. But the physicians are private, the hospitals are all private. But there's because it's only one payer in Canada, they tend to have a pretty strong ability to negotiate, particularly with prescription drug costs, which is why oftentimes the drugs are cheaper in Canada than they are in the US, and you have that kind of challenging conversation each year as it comes up about how we are paying more for drugs than people across the border in Canada. Again, the risk is spread across the entire population, so everybody's covered. And so let's talk about what this feels like. First of all, you can go to any physician you want, no problem going to whatever physician you like, but you don't always have all of your costs covered. So you may not pay anything for your physician, usually you don't. It's very difficult to get a specialist referral, but you can get one, and you can't see a specialist without a referral, so you have to go to your physician and then get one. Um, but you don't pay any fees to the physician or the hospital, but you will pay for your drugs. So you may not pay a lot for your drugs, but you do pay. Like in Japan, the national health plan covers about 70%, or actually only about 30% of the cost, so 70% of the cost that the patient has to pay. Um, and then the prices are really decided by the government. There was a really great article in Reuters from just February of last year that reported that the government was considering shifting more of the costs for drugs to patients. So I've included that in the reading portion of this section. And then important to know that in Canada, pharmacists' prescribing privileges vary by province. So, like in Alberta, Alberta gave pharmacists independent prescribing privileges. In Quebec and British Columbia, they only allow prescribing for defined formularies. So that's another thing to know if you're launching into Canada, is that you also want to have the pharmacist as part of that campaign. Lastly, we'll talk about the out-of-pocket model, and the out-of-pocket model includes, countries like India and Africa and South America, and these are usually countries that are a little less developed. You have developed, industrialized countries that have established healthcare systems, but most nations on the planet are frankly too poor and don't have as an organized structure. So they can't really provide any mass medical care. So they work on a traditional fee-for-service model, like we talked about earlier in this session, that the U.S. had, when we first started out as a country. So the risk is not managed, so it's not insured, so there's very little preventative care. Many hospitals are owned by the government because it's very expensive to be a hospital. With so many people not having care or not having money to pay, it can be really difficult. So how does this work if you're a patient? Well, you can pretty much go to whatever physician you can find. So another last thing to talk about, like pharma marketing outside the U.S., you want to kind of think about some restrictions. So the U.S. allows branded marketing to the general public, or direct-to-consumer ads, DTC. But in other countries, that's not allowed. But that doesn't mean that you can't market your campaigns effectively directly to patients. You can. You just need to follow some rules. So the main rule is that in most countries, it's acceptable to promote disease awareness to the general public. So that's called unbranded advertising. And so websites, television ads, your digital marketing, all focused on helping patients learn about the condition, encouraging them to ask their doctor for more information, and then asking them to opt in for additional information and messages about a treatment. So once a patient opts in for those messages, then you can start sending the branded marketing. And you can send those through email and direct mail. Now, many patients sign up for patient support programs, and these sometimes also include regularly mailed communications. And so this helps for pull-through and to create some interest generated from those. Some things to be aware of is that, physicians, you usually have many more options. You can target branded marketing to physicians, and there's and also disease awareness, so both of those are available. And then you have a lot of different things that you can do. Email is sometimes restricted to a certain number of emails per year, so you have to know what that restriction is. The direct mail is usually restricted by the number of pieces per year, and then rep detailing sometimes also has restrictions for the number of visits. But you can typically do just about anything you can in the US, but you just have some additional guidelines to follow. You typically also have a pharma marketer as maybe a kind of a partner to your client in the U.S., and that pharma marketer in market, or that in market client, is a great person to work with, but they are likely managing the several brands at a time. So sometimes it needs to be really turnkey. When you send them materials for them to run and market, they almost need to be very easily customizable by an agency in their market, or working with you to customize it because they don't have a lot of resources. Next, let's talk about tender agreements. This is the last thing I wanted to touch on in this section. It's important when you're launching drugs in other countries to understand the tender agreement process. So a tender is this unconditional offer of money or service, in exchange for some sort of, debt. So you would say, I will, pay you money for some sort of service. And if you don't provide that service, then I get my money back. So it's kind of a tender agreement's a little bit different in that it's kind of like you are always able to get your money back. So these are usually regional contracts, and they control the ability of your clients to market and offer their drugs in a particular market. And they will typically be contracted with multiple different brands at one time. So your clients will probably not be part of it. There's usually a different group within the pharmaceutical company that works with these tender agreements and these government offices. But you may hear that the brand is locked out of a country. And that can happen because a competitor might require exclusive access from a tender agreement in exchange for lower prices. So oftentimes, especially when you have like a new therapy area and you have a couple of brands that are first to market in some of these countries, they'll go lock up the tender agreements for a period of time, maybe 10 years, and they'll offer their drugs at almost no cost or very low cost with the idea that they're going to be able to lock out the competition. So that's why it's kind of important. So what happens in a tender agreement is that the pharmaceutical company will get all these rebates and discounts, and they'll get their merchandise stocked. They'll promise that there'll be no disruption to distribution, and then the regional plan will put the drug or the pharmaceutical product on their formularies and encourage that people can get that. So it's going to be kind of an important process to go through, an important thing to understand. So that completes our lesson on the U.S. and global healthcare systems. I hope you've enjoyed learning about how healthcare works across the globe. As you work with your clients, the ability to understand and anticipate the needs of the brand in other countries will help you with your global brand launches. Please take a look at the readings I provided in this lesson for more information on health policy, and if you'd like to dig deeper into any of those areas. Thanks. See you in the next lesson.